Session 11, Mixed Bag Part 2. Let's start this session on a lighter note. Mixing one's wine may be a mistake. Of course, it's a mistake. We are in a dry state, right? But old and new wisdom mix admirably. Now, let me invite our today's chairperson, Dr. Talika Doctor, Professor and Head of the Department Anesthesia, BJ Medical College, Ahmedabad. Dr. Bhavesh Shah, Senior Consultant, Physician, Koparvanj. Dr. Vimal Patel, Senior Consultant Intensivist, Pulmonologist, Balashinor. Dr. Atul Gandhi, Senior Consultant Anesthesiologist, Ahmedabad, Honorable Secretary, ISA GSB, Vice President in AMA 2016, Treasurer of ISA GSB 2016-2019. I invite Dr. Amit Prajapati, Consultant, Sri Krishna Hospital. Consultant Physician, Anand. I invite Dr. Amit Prajapati, Consultant Physician, Anand. Topic for our first talk in last session is identification of potential organ donor, brain death declaration, challenges and practical consideration. For this, I would invite Dr. Tapan Sahoo, MD FNB, FICCM, FSNCC, FCCP, EDIC MBA, Canadian Critical Care Fellowship, Associate Director and Head of Critical Care. He is currently affiliated with Medanta Hospital, Ranchi. Area of expertise, neurotrauma, focus, stimulation and core teaching. I invite Dr. Tapan Sahoo on stage.
So, good afternoon everybody. I know after the high voltage discussion on something related to sepsis, we are entering into something we don't practice daily, or maybe there are many gray areas that we need to be really thorough in our clinical practice. So with that background, the topic, slide changing, slide changer, that brain death detection and organ donation, and I have deliberately kept the title as the art and the science, because it's not always the science which is prevailing in the brain death or the organ donation part. Why I have kept this one? Life is uncertain. So what is certain? If somebody will ask, maybe it is a little bit a philosophical question, but I would say death is certain. Yeah, but not in a negative way, but yes, like life is like that only. And we all know the common outcomes. One day, everybody has kept this in mind, but the outcome can be changed if we'll think in a little bit different way. And that's the reason why we have kept the topic title, the art and science. I would start with a real case, and this case you can say it is a normal day-to-day affair in our ICU, BG ICU, a neurotrauma ICU. A 41-year-old male, day 3 in the ICU, and the history was patient is a known attempted self-hanging case. Asystolic at the site of the presentation, the ER team, they just took the patient, transferred the patient to your emergency department, and now after day 3, whatever you have resuscitated, now this patient is, you are getting the GCS of 3 and no brainstem reflexes present. Very typical case, everybody is aware of this type of scenarios. Now you are the person who is the attending, and he is directed to assess the patient for brain death. So how you do proceed? So my talk would be based upon these following headings: the brain death history, the pathophysiology, the way how we can go ahead with the brain death detection, then the legal aspects, and once you declare the patient to be brain dead, how you do maintain that patient if you are deciding for organ donation, which is the expected outcome rather than the common outcome what we are actually doing in our ICU day in, day out. And what are the controversies, the challenges and the practical considerations that can happen in the brain death detection as well as the organ donation. Do you know, like 40 to 50% of the total road traffic accidents, the cause of death is almost, you can say, head injury. And we all know the scarcity of the organs for the donation. But if these 40 to 50% of the road traffic accident 2017 data is 1.5 lakh fatalities. So if those patients who are, we are actually right now detecting brain death and declaring death, if 4 to 5% of those patients will be selected for the organ donation, can you imagine we won't have any scarcity of organs? Maybe it is the title topic on which I am discussing, that's why I am telling, but it's a fact. It's a fact. We can save so many people's life if we can just take 4 to 5% of the total road traffic accident patients who have not survived. And on that background, 1994 was the year when brainstem death was legalized in India. And after that, in that same year, THOTA Act, THOTA is for Transplantation of Human Organs Act, that was passed in our assembly. And following that, there are two amendments happened in 2011 as well as 2014 further to that 1994 Act. And we in India follow UK guideline. This is for the young trainees, it's not USA, it's not like other European countries, it is UK guideline. On that basis, our Indian Transplantation Act is based upon. You can see, it's not a very good picture, but you can see in India, the organ donation rate is mere 0.8 per million. While in Spain and USA, they are way ahead of us. So if you will say, when the world is doing so well, why in India we are lagging behind? That is a question to think about. And maybe that will be the take-home message from my talk. So we all know the theoretical aspect. I would be a little bit faster because the time is running away. We all know how we will diagnose brain death. Three things: coma, absence of brainstem reflexes, and finally apnea test. But there are many things we need to consider when we are going for the brain death detection or diagnosis. That we need to know the preconditions, the confounding factors that can be like mimicking the patient to be completely sedated, the GCS to be 3. So we have to exclude those factors, then only we can go ahead in diagnosing or detecting brain death. And there has to be absolutely normothermia, normotension, no sedation or analgesia, absence of, you can see here, sorry. So the electrolyte panel has to be perfectly okay, the metabolic panel has to be perfectly okay, and at least you need to have one eye and one ear to go for the oculocephalic as well as the oculovestibular reflex. Now, the examination part, we all know we need to go for the complete brainstem reflex test. And you can see here, all the cranial nerves have to be examined. All the cranial nerves, starting from 1 to 12. And you can see here that it has to be done by two independent clinicians. One has to be neurologist or neurosurgeon, the other can be intensivist, anesthesiologist, physician, whoever is present in your ICU. And it has to be sequential. You don't have to wait for 2 hours for doing one repeat test. And time of death is the completion of the second examination. It cannot be first examination. So there are many limitations to the, you can say GCS of 3. Sometimes we are getting spinal reflexes named as Lazarus sign. So that will mimic, you will be confused whether to go for the further investigations or you have to wait. That you can see in almost 20% of cases. You will get, that can be in the form of, you can see here, pronation extension reflex, abdominal reflex, flexion reflex. That would be misinterpreted as brainstem function, but that is not at all the the concern for us. That is normal. In almost 20% of cases, you will get this type of reflexes. Apnea test, everybody know, you can take a picture of this, you will get in Google. I am not going into detail, but yes, apnea test, you have to be thorough, the prerequisites, the conditions, the other, how will you interpret the apnea test, that is very important for the final brain death detection. So there are certain situations when you want something else. It's not only the apnea test. That when you don't get a clear cause of the catastrophic brain injury, that is point number 1, any confounding factor is still there in the body after waiting for 24 to 48 hours also. Third point, when you are not able to do apnea test, maybe the patient is so much mutilated, you are not getting a ear, one eye, or like the patient is too much hypoxic that you cannot put the patient on, like you cannot take the oxygen out. So in those conditions you need something else, and those are EEG, though it is not a recommended test to go for the brain death detection, and maybe you can go for radionuclide scintigraphy. And the sign, the typical sign in brain death is empty skull sign. You are giving the radionuclide dye in a peripheral IV that should go into the cerebral perfusion. But when the patient is brain dead, the blood circulation is not there, so you will get the skull to be completely empty. So in the picture you would get like it's to be empty. So empty skull sign. And nowadays we need to go for also transcranial Doppler at the bedside. It is a point of care testing. You can do multiple times. You can do by different examiners, so that at least your diagnosis is not having some confusion. So this is a checklist how you should proceed for the brain death detection. Now, once you have diagnosed that this patient is brain dead, now the next $1 million question is, can my patient is fit for the organ donation? But again, myriad of questions are there. It's not so easy. But we need to understand what is happening in the brain dead patients, so that at least we should be ready to take care of the patient who is a potential organ donor. So you can see here, there is hormonal deficiency, there is cerebral systemic inflammation, catecholamine storm has happened when a patient has suffered brain death, and finally leading to hemodynamic instability and metabolic failure. So we have to at least start some resuscitation or treatment, so that my patient is not having this hemodynamic instability and metabolic failure, so that I can prepare my patient for at least 1 day or 16 hours, 48 hours, so that at least a potential organ recipient can be there, so that I can donate the patient's organs. So that is the whole idea of knowing the pathophysiology. Now, we need to know certain things, certain technical terms, organ donation type. One is living related, one is living non-related. So we all know the concept behind what is living donor, what is non-living donor. So cadaveric donor, the living non-related is cadaveric donors. So, and the cadaveric donors are currently the major source of the organs in India. It's not the living related or living unrelated. There is one more terminology, donation after circulatory arrest or circulatory death, that is DCD. One is brain death, which is the neurologic point of view, but when you are going for taking the tube out, when you are thinking that this patient is not going to survive because of some prolonged cardiac arrest, the patient is hypoxic brain damage, something like that, when you are actually going for DCD, that's it, death after circulatory, declaration after circulatory death. Then there is another terminology, opt-in and opt-out. Opt-in means when the donor gives consent, and opt-out is you don't need any consent. It is by involuntarily this person is actually going for organ donation. In Western countries, if it is not written clearly, it is always opt-out. So you have to tell that don't take my organs when I am dead. Then only the legislation or the doctors will restrict organ donation in that patient. So that's the reason why the other countries are doing good compared to India, because here we have to write in proper way that I have to give my organs when I will be dead. That is opt-in. Then what is the role of intensivist in the potential brain dead patient? We all know we have to maintain the hemodynamic stability, diagnose the death, preparing the family for the devastating news. That is also the responsibility of the intensivist, along with counsel the family, implement policy and protocols for the organ donation, and you have to communicate with the transplant coordinator, the organ procurement team, and family members. The immediate steps what you should do, sometimes we are confused. We immediately inform the family relative about organ donation. No. As we are the treating team, we should not be involved in that business. There is a separate organ procurement team or a social worker team in your hospital or respective ICUs or hospitals They have to be involved in all those things. If you are involved, then definitely there will be a difficult situation that can happen medico legally, that you are involved in trafficking of the organs. So that's the recommendation. The family should be explained. You can just take care of the families, like like the agony as well as their own concerns, but you should not be discussing about the organ donation. Priorities, you have to maintain so many things. You have to go for tissue typing, organ function testing, viral screening, then maintain the extracerebral physiologic stability, facilitate family at the bedside when you are going for brain death. When I was doing my fellowship in St. Michael's Hospital, Toronto, 3 times I was at the bedside when we are going for DCD, that is declaration after cardiac death. In Western countries, they don't depend upon brain death, they go for DCD. When we are thinking that this patient is not going to survive, we explain to the family. In presence of the family relatives, we just immediately reduce the FIO to take the tube out also. And at that time, it is a very emotional, touchy moment, that you are taking the tube out, the family relatives are surrounding. As a doctor, sometimes you get some abnormal responses. Once upon a time, when there was a patient, after taking the tube out, saturation actually improved from 68 to 90, and the patient started moving the hand. Can you imagine the situation? My senior, who was the attending, I was the fellow, he was slightly thinking that whether we have done a right thing or not by taking the tube out. So you can imagine the family were looking at the doctor, doctor, have you taken the right decision? Is my patient is surviving by taking the tube out? So that is little bit awkward situation that may happen during this situation. Now, management of organ donation, I am not going into detail, but yes, the general management, the monitoring part remains same, just like a critically sick patient in your ICU. How we are going ahead. These are the normal things, but in organ donation, you may go for IgG, IgM, CMV, as well as HBV, HCV, and HIV, along with the other typical investigations that we do. General resuscitation, very important. Don't think about giving high dose steroid, that it will go for neuromuscular weakness. Anyway, you are going for organ donation. How it will affect if you are giving 1 gram of methylprednisolone. The goals of potential organ donor, simple method is rule of 100. For the trainees, just remember rule of 100. How 100 is important? You have to keep the systolic blood pressure more than 100, urine output more than 100 per ml per hour, PaO2 more than 100 millimeter mercury, hemoglobin 10 gram per deciliter or 100 gram per liter, and blood sugar more than 100 milligram per deciliter. That is the rule of 100 that we need to keep in mind when we are dealing with this type of potential organ donor in our ICU. We have to keep a track on the hypovolemia. We have to be judicious in giving fluid, because if you are thinking of lung transplant, maybe organ donation for the lung, we have to keep the lungs little bit drier side. Otherwise, it will be not a good ideal organ to be harvested. Corticosteroids, we all know the reasons why we want to give corticosteroid in these type of patients, because brain death can cause pituitary deficiency, promoting hemodynamic instability. Steroids will reduce inflammation to certain extent, and that would improve the organ function viability in the potential recipient. And you have to give large doses up to 1 gram methylprednisolone daily. Don't think about neuromuscular weakness, secondary sepsis. Anyway, we are taking the patient's organ in a viable situation. Management of diabetes insipidus can happen. Diabetes insipidus is a common complication in this type of patients in brain death, and for that we need to know the treatment options. It can be desmopressin, it can be vasopressin infusion, but you need to maintain the osmolality in these patients, otherwise the patient graft will not be a good viable thing for the recipient. Cardiac function, there is no need of noradrenaline dobutamine. Just give high dose of thyroxine, because these patients are for maintaining the cardiac function. If you are giving the thyroid hormone, that will act as cardiac stimulant, and the doses is still not very clear, but definitely you have to keep in mind or track. Avoid subclavian central line if we are thinking of going for the lung harvesting, because that may go into pneumothorax in those patients. So you are actually jeopardizing the viability of the lungs. Bronchoscopy is required to evaluate candidacy for the lung transplantation donation, but try to do it as quickly as possible, because it's an invasive procedure. Sometimes you are giving the patient some infection, and that will be like one hindrance for the proper viability of the lung in a donor, like recipient patient. And avoid volume overload. Sometimes they say APRV is a good mode for keeping the patients on ventilator. Temperature management has to be monitored. Empiric antibiotics, sometimes piperacillin tazobactam is a good choice for keeping any secondary infections not coming in. There are certain challenges, that is the third part. One is you have to identify the potential donor. Brain death determination is again a challenging job. Donor screening, approaching the family, and finally authorization from the family. It has to be all done simultaneously by different teams, but you have to be the pilot of that team as intensivist. So there are certain questions. If the patient is on ECMO, are the principles same as normal like patients who are on ventilator? There are certain caveats for that. I am just highlighting it. Apnea testing is still recommended if the patient is on ECMO. Pre-oxygenation, for that you have to make the FiO to 100%, and minimize the sweep gas flow rate to almost 1 liter per minute, so that your carbon dioxide, when you are going for apnea test, your targets for pH, CO, everything has to be normal. But sometimes TCD, I will take 1 minute sir more. TCD, normally we are going for the brain death determination. In those patients in ECMO, you may not get a good TCD flow. Why? Because for TCD, you have to get a pulsatile blood flow. But when the patient is on ECMO, you will not get a typical pulsatile blood flow in the cerebral circulation. So it will be confusing if you are only depending upon the TCD for the brain death determination. That is one different aspect what I want to highlight here. In USA, they want only one apnea test. That is the difference between USA and UK. The age-old rivalry between USA and UK. But in UK, you need to have 2 apnea tests to confirm that this patient is brain dead. And as India is following the brain death guidelines from UK, so we also do 2 times apnea test for that final determination. So that is one different point. In India, you can see here 2 tests. Second test after an interval of 6 hours. And when you do the second test, that is the time of death. That is the time of death. Now, it has to be a team effort. There are certain challenges. I don't know the answers. The next 4 slides, I also don't know the answer. This is for the audience to ponder about. What could be the reason and what could be the solution? Why is the donation rate is so poor? Where do we need to work on? Is it the medical profession we are not focusing or selecting the correct patients, or is the public at large? Again, there is no right answer, there is no wrong answer. Now there are certain myths that I want to highlight here to the audience. If I am in an accident, the hospital will not save my life knowing if I am an organ donor. They may side me because I am an organ donor. So maybe I am least preferred patient for them. I have already donated my kidney or liver or something like that. That is a myth. But no, it should not be. Too old to donate. What is the age that could be, you can say, too old to donate? Rich and famous only receive organs. The poor people, they won't get any organs. If the organs are donated, there is a perception that body is mutilated and funeral is jeopardized. Again, that is a myth. Disease to remain complete after death, otherwise you will reborn with deficit. That is again a myth. People normally think that if the kidney is out and I will die, maybe next birth I will get a birth with 1 kidney absent. That is also one myth that we need to change. And my religion does not permit organ donation. That is also there. Again, we are not highlighting about some religion, but yes, these are the certain myths we need to understand, and we will try to increase the awareness so that the organ donation rate will increase. Otherwise, we will be always seeing the graph to be like that only. Kerala is the only state, we can say, they are literate 99.9%, and they have in 2020 January, the government has given the authority to the doctors in the critical care or the neurologist that they have the right to decide whether the patient certified as brain dead needs to be taken off life support for organ donation. So that is the recent news for India. There are certain recipient or family donor issue, that who the donor is, age of the donor, what is the donor suffering from, the region of brain death, and if my patient is suffering from hepatitis B, can I donate organs? So there are many things from the donor issue that we need to understand. From the family issue, organs are donor family, can they have a say who will get the organs? That is also a question. Sometimes if family wants that my patient's organs, I would be the person who can decide like who to get the organs. That is also certain issue. And there is a concept called directed donation. What is the directed donation? Directed disease donation, DDD. That means, I will give an example. My nephew was a bright young child who had just finished his MBA. His death has shocked everybody. Keeping our grief aside, we wanted to donate his organs, right? But to my one of our relative, not as per the policy or the law, can it be possible? So that is named as directed disease donation, means the family has a say in deciding who will get my own relatives' organs. So that is again a confusing part. In India it is still prevalent, and people say that we need a authority over who will get the organ. DCD, I have already told, it's a vast topic. That is, instead of brain death, now if your patient is not salvageable, we'll go for DCD, that is declaration after cardiac death, and we can take the tube out in the ICU or in the OT, in the OR, and take immediately the patient, the organ, to harvest in the recipient. That is DCD instead of brain death. Because brain death we are not getting organs. For DCD we will get organs in our respective ICUs also. In your ICUs, 1 or 2 patients would be right now in that stage. Last slide. This is one agonizing brain death case. I don't want to because we are running out of time, but these are two very interesting cases where there was so much of gray areas, challenges for the clinicians as well as the lawmakers, whether to go for brain death declaration, whether to go for organ donation. You can we can discuss it later on. But the challenges definitely in life also there, in death also there. So with the patient is dead also, there are so many challenges. We cannot get the patient's organs also. If you are getting also, who will get the organs? That is also a challenge. So challenges definitely keep us grounded, and we need to find a solution how to improve on that, because life is amazing and it has to pass on. It cannot be end at one point of time. And that is the message with which I want to end my discussion, that quality is an endless journey, and we need to be thorough all in the brain death detection as well as increase the awareness about organ donation. Thank you.
Thank you, Tapas.
Thank you so much.
Such a nice presentation. Just for awareness, in Gujarat we are doing the number of awareness camp, and also the national call is there. So the first line is you mentioned if I will consent the organ donation, but there is a clause always there. The relative also confirm the organ donation, then and then it's approved for the donation. So awareness is a far better option for the organ donation. So we whole team make an effort and go for the awareness of campaign. We are doing in the school, colleges, we take a consent. So awareness only answer. Yes. Thank you very much. Such a nice presentation.
Thank you so much, sir.